Yo, solving COVID-19 with Dr. Raywat Deonandan. Episode 25 coming at you. Let's do this.
Welcome to Solving Healthcare. I'm Kodjo Karamantang. I'm an ICU and palliative care physician here in Ottawa and the founder of Resource Optimization Network. We are on a mission to transform healthcare in Canada. I'm going to talk with physicians, nurses, administrators, patients and their families because inefficiencies, overwork, and overcrowding affects us all. I believe it's time for a better healthcare system that's more cost-effective, dignified, and just for everyone involved.
Thank you, everybody, for listening to Solving Healthcare. We're on episode 25 already, and thank you for your continued support. And we're going to continue to try and provide you with the most reliable COVID-19 material as possible. And our guest today, Dr. Raywat Deonandan, is like, you guys are going to love this episode. Like, in this episode, we talk about how social isolation is working, the importance of increasing testing, especially having reliable and quick test results. We'll talk about how, in his opinion, we're about 2 weeks away from flattening the curve. This interview took place March 31st. And we're also talking about future treatments for COVID-19 and what the possibilities are and much more. What was great, though, is at the end of it all, he really left you with a feeling of optimism, which is something I feel like is lacking in this conversation. All right, let me tell you about our sponsors before we jump into it. BetterHelp. I love these guys. This is an online counseling service that provides accessible, affordable, and convenient counseling to those in need. And whether it's a struggling teen, whether it is couple counseling, whether it's healthcare providers that are struggling with compassion fatigue, they provide all these services. And this is through video chat. This is through texting. This is through email. This is through phone calls. So it's convenient. It's reliable. They provide an amazing service. So use promo code Solving Healthcare and get 10% off sign-up fees. I'm super excited to tell you about our second sponsor, Audible.com. And I don't know if a lot of you are book listeners, but I've transitioned to listening to most of my books about 5 years ago through Audible, and it's completely changed my game. Like, I went from reading a book a year on vacation to listening to anywhere from 12 to 18 books a year. And honestly, I don't know if we'd be doing this show right now if it wasn't for some of the books that I listened to, for example, the 4-Hour Work Week or the 80-20 Principle. All these had helped enhance my productivity. So I'm a big fan. I know my wife, I know my mother-in-law, we're all Audible members. So, if you use the link attached to the show notes, you get a free month of the Audible service. And if you do sign up, you get a book a month plus 2 Audible originals a month plus 30% off any additional books that you purchase. So I love these guys. I love this service, and it's a game changer. Okay, guys, let me tell you about Dr. Raywat Deonandan. He is a scientist, an award-winning, best-selling author. He's an associate professor at the University of Ottawa through the Faculty of Global Health Sciences. He's a former chief scientific advisor for the federal government and a blogger, podcaster, just an overall wonderful human being. So without further ado, Raywat. Ladies and gentlemen, we got Dr. Raywat Deonandan in the mix. How are you doing?
I have acid reflux. We've talked about that already. But I'm doing all right.
Can I just say how much I love that answer?
There's only 2 reasonable responses to how you do it. Fine or something quick and funny. Nothing else is acceptable.
I love it. Speaking of funny, you and I have something in common that I don't think we've talked about.
Both really handsome.
Well, we are pretty. It's too bad we're not looking at each other, but we are both pretty. But we are both haiku enthusiasts.
Oh,
you know what I mean? Like, it's a very underappreciated poetic form. You know what I'm saying?
Yeah.
All about that haiku. Listen,
What a way to start. Starts with in the midst of a global pandemic, we start with acid reflux haiku.
Yeah. By the end, I will have a haiku about pandemics and acid reflux. Listen, what would be your message as an epidemiologist to our public? Like, what's some of the themes that you're concerned about or want to express?
I have an ongoing mantra that I repeat at every media engagement, and I'll tell to anyone who asks about this crisis, and that is, it's not necessarily a health crisis, it's a health systems crisis. And the distinction is that a health crisis, managed mostly by clinicians like yourself, we wait for salvation from an external source, like a vaccine. That's how most people think about a medical crisis. What's the cure? What's the therapy? A health systems crisis, on the other hand, relies upon salvation from within, using technologies, resources that are currently with us. All a health system crisis needs to abate is leadership, preparation, resources, and appropriate investment. We can do all that now. It just takes, organizational acumen and political will.
So what does that really look like in terms of where we're at with COVID now? So this interview is on March 31st. We're seeing different numbers throughout the country. Like, we're seeing a deceleration in British Columbia, not 100% sure today what the numbers are looking like in Ontario. But what do you think we need now to be able to get a handle of this?
Well, as an epidemiologist, my answer is always going to be information. So data drives the best decision making. And I'll get back to answering your question in a more straightforward way in a second, but I've been following the big name epidemiologists in the world as they comment on this, have been retreating to the very comfortable but problematic contrarian position that without appropriate data, it is inappropriate to act the way we've been. For example, John Ioannidis famously wrote this article a few weeks ago saying that the data currently do not support these extreme economic measures of lockdown and so forth. And the pushback, I think, is that in absence of perfect data, we make decisions based upon what's available. And the temptation is to view all of this through a evidence-based medicine lens, which has a high threshold for action, rather than a public health lens, which has a low threshold for action. All of that is to say, ideally, we would need better data collection regimes in order to guide decision-making down the road from an evidence-based lens. Right now, we make do with what we have. Right? So what we have? We have some caseload information from the sporadic and inconstant and non-ideal testing that we currently have on this country. Given what we see from this inconstant, sporadic, and imperfect testing, we see spiking in some jurisdictions, but the expectation is that the curve is going to bend in 1, 2, possibly 3 weeks. At that point, what we need is an outrageous military-style deployment of public health infrastructure that we've never seen before. And that public health infrastructure at its core is all about testing. Testing. That's how we get out of this, with the technology that exists today that is testing. We just got to buy a bunch of tests and deploy them strategically.
So there's so many questions here. So you think with our current measures, with our social isolation, in your humble opinion, it should have some impact on the curve?
I think so. That except if people aren't taking the distancing and the isolation seriously. I mean, the two models are the suppression model and the mitigation model. Mitigation model is social distancing, or physical distancing as we call it now. So, reduce the rate of spread and therefore the rate of new case production. And you maintain the new case production at a level manageable by the healthcare system, but you still intend on infecting everybody eventually, right? And that's going to have some kind of disarray in the economy lasting many months possibly. The other model, the suppression model, has a hard lockdown, and we force the rate of new cases to dwindle down to a simmering boil in a matter of weeks. I think that's kind of where we're inching towards now. In absence of that approach, we risk having economic impacts that might be almost as bad as the disease. You had Paul Offit on last week, and that was a great interview.
Thank you.
I listened to that with great intent. And he made an interesting point. about just that, about we need to pay attention to the public health impact of our intervention itself. And that's coming for sure. So given those two options, suppression and mitigation, I think right now we have to think strongly about hard suppression in order to soften the economic blow. But the reason that epidemiologists early on, at least some, particularly the ones in England, were pushing for the mitigation path was that the suppression path means that you get the number of new cases down to a simmering boil, but they're coming back in a couple of months, right? So you have these rolling waves of suppression and relaxation, whereas the mitigation approach doesn't. This only works, the suppression only works as a long-term strategy, in my opinion, if we follow it up with this enormous flood of testing, contact tracing, and public health powers. Wow. Kind of like what they do in Singapore and South Korea.
Wow.
A whole bunch of other questions like, what are the cultural and political differences in these countries? And how do we make it happen?
No, but I mean, sorry to interrupt, but I think part of coming up with the answers to know just the general principles, because a lot of the times we have these conversations with the short-term consequences in mind, not thinking of the long-term implications. So what I like that you mentioned about the suppression is being like verbalizing that this doesn't fix the problem, that this can come back. You know what I mean? Like, I don't know if the general public thinks of it this way. And so this is why I think it's important to mention like the value of why we need to have testing as a key measure to be able to manage these things. And so I didn't mean to ruin your flow, so you could ignore this. You could ignore this question too. But with the mitigation theory, like, do you think it is a reasonable approach if, in terms of weighing out all the kind of benefits and costs, knowing that potentially is our testing going to be ramped up in a short period of time?
All this depends upon the ability to get the right test kits and to deploy them strategically. And I think it's the right path, the suppression and testing path, because our biosciences sector is up to the task. And we see the major countries, US, Canada, Britain, investing heavily in getting those tests on the ground as quickly as possible. One of the key tests that we need is the serology test, the antibody test. And I read, conflicting reports on how we are or where we are in that development and deployment. So I know England has ordered antibody tests directly from a manufacturer, whereas the CDC website says they're still in development. So I'm not sure what's true in all this. But as you're aware, the serology test measures whether or not someone is or has been exposed to the disease, meaning that it can tell us if people are already immune to it. And that will hasten our path to herd immunity. And we can return to some semblance of normalcy quite fast. An important consideration to quell people's anxiety about this is to remember every time someone gets this and recovers, that person is now recruited back into the economy to keep things running. So for every infection, it probably means it's someone who's going to be a contributor to the solution in 1 month. Right? So think about it as a machine cranking out susceptibles from one pile into recovered in the second pile. And that recovered pile represents people who will help us. So it's bad to be infected. It's bad to get sick. It's bad to die, obviously, but it's really good to recover.
Absolutely.
So the goal eventually is going to be global herd immunity, which comes in one of two forms. Either this natural way through our management of the suppression or mitigation waves, or artificially through the arrival of a vaccine, which won't be for 2 years probably. But that's where we're going to end up eventually with global herd immunity.
Yeah. So I guess that is why I don't mean to belabor this, but that's why I'm wondering a lot about the mitigation. In a controlled way, having some of our population develop immunity. It's in some ways I wonder if
Yeah, it's not an insane idea. It's not insane. I mean, and this is originally, I think, argued for by the Imperial College of London, by Neil Ferguson. I don't put words in his mouth, but I think that was his argument. And UK government, that is sort of their plan, right? So they don't want to stamp it out entirely. They want to maintain some kind of community activity in order to have a bubbling amount of infections manageable by the NHS. I think that's their approach. The problem, though, is that approach assumes that everyone's going to get infected anyway, just manage their timing, and accept the deaths and the suffering that will come with it. An alternative view is that if you can delay the infection longer, that buys us time to develop better treatments and mitigate and prevention protocols. The treatments are coming down fast and furiously from our laboratories, and many are showing some promise.
Yeah.
So I think it would be tragic if we had this strategy to encourage some people to become infected now and some die of it, and 6 months from now we have a viable treatment.
Yeah, I think that's a very important point. Like, like honestly, I don't have a finger on the pulse at all, but if there are solutions, because I don't think the vaccine one is legit, in my opinion, because it's so far down the road. But, if we have other measures that are coming down the pipeline that potentially are months away, that's a different story, because as you said, we don't want to have unnecessary deaths if we could have solutions months down the road.
I mean, some of the promising ones include the plasmapheresis treatments, right? And those are being implemented right now. They're showing great promise.
Are they being implemented? Yeah, I wasn't sure if it was mostly just, well,
it's not widespread implementation. It's on a trial basis. And I think Toronto Hospital has ordered some plasmapheresis from China.
We'll update the notes and stuff closer to release date, but we also want to do a show about that as well, actually. But no, that's a great point though.
Right, and we don't even know what this disease will look like in a couple of months. It is mutating, as all viruses do. I think it's foolish to assume it will mutate quickly into irrelevance, but it's possible. Right? So again, it would be tragic if we encouraged a bunch of people to get infected in the short term and suffer and die when a few months from now they would.
Yeah, and you do hear a lot of talk. It's so hard to get reliable info right now, and it's part of the goal of our show that people could get some reliable information about COVID. But it's hard to, like, you hear a lot of people talk about we're going to get a second wave in the fall, and maybe this is going to be suppressed in the summertime because maybe there's some climate implications. But to be honest with you, as you said, we really don't know. Like, these are just educated guesses,
This is going to change so many things, especially how diseases are portrayed on science fiction TV shows. Right? So, those shows, hey, the epidemic breaks out, 24 hours later, there's a vaccine, everyone's cured. No, it takes a long time. It takes a long time to collect information, process the information, and understand what it means. What I find so interesting about all this, well, so many things are so interesting. One of them is we live in the information age. We couldn't do what we're doing now, even having this conversation 5 years ago, it was not as advanced. And yet there is a slowness in collecting, processing, and sharing.
Isn't it crazy? Isn't it crazy? It's 2020 and how slow, excuse my French, how how information gets processed and disseminated.
Yeah, I don't understand it.
It does not make sense.
Preaching the virtues of surveillance for a long time. Every epidemiologist understands that we need to know where the diseases are, who has them, and when they're going to come. It's a low-tech, easy way to prepare for these issues. And we have wonderful surveillance systems around the world, but it's amazing to me how slow it is to get the information about the number of tuberculosis cases in a given country, for example, and who they are, what their genders are, what their underlying conditions. And yet it's like pulling teeth. Even I'm trying to figure out in the USA, who are these people who are being hospitalized and dying? What are their underlying conditions?
Impossible.
Sporadic information. Impossible. Yeah, it's impossible. And it shouldn't be.
Because I asked that question, because we're starting to see cases in Ottawa now, right? So, but some of the information that I would love to know is, how comorbid are the patients that end up, for example, in critical conditions? Like you'll hear these spot extreme examples of, oh, this healthy so-and-so-year-old got admitted or whatnot. But like, is that the norm? Is that a small percentage? You know, Are they obese? Do a lot of them have hypertension, diabetes, what have you? This information, at least from what I'm seeing, and I'm not looking at it with an ultra super lens there, but I'm not getting that. And how valuable would that be?
So this is a health systems failure because the information exists somewhere in the system. It's not being concatenated and processed in the appropriate way. It's not being given to people who need to know it. And imagine, think about how that information could be well applied. It could be well applied for planning purposes, for staffing your hospital, and it can be well applied for how we plan our approach to the epidemic as well. A lot of people keep asking me, why don't we just lock up the vulnerable, let it run rampant through the community, and the non-vulnerable will become immune in 2 weeks, and then the vulnerable are safe. And my answer is always, who's vulnerable? We don't even know, right? We assume it's the elderly, but it's not. We assume it's the immunosuppressed, but it's not just them. We would know if we had this information, but we don't. So that kind of information, if it was at our fingertips, could be a game-changing lever on the strategic choices we make at the public health level on how to put an end to this.
I mean, you and I don't know each other, but one of my big passions in research is big data, like doing a lot of big data research and how, to be honest with you, even in Ontario, through ICS, there's a ton of amazing, beautiful data that people just do not tap into.
Yeah, it's interesting, right? And it's interesting looking at who the leaders are in presenting the information. I was on I'm going to plug myself for a second. I was on a British TV yesterday, and we're doing myths and facts of COVID. And where's I going with this? Oh, yeah. One of the questions was, where should people go for information about this disease? And most of the panelists were saying, government websites, but someone else said, yeah, but some governments are propagandizing the information. And someone else said, WHO, yeah, but WHO is kind of slow in publishing their data. And then I find that universities do the best job. Not all of them, but some of them. So there's some key loci in the community that are processing data very quickly and sharing it in novel ways, like data visualizations and interactive maps. And that's very inspiring. It's interesting to me that on the one hand, you have highly responsive and highly technological methods of engaging the public and researchers with prime data. On the other hand, you have a failure of our old institutions, like public health, like government, to get that same data out in a way that is inspiring and useful. If you go to, public health PIAC website, and I'm not criticizing, God bless them, everything they're doing right now. But the kinds of data that they're releasing to the public, highly processed. And from a researcher's perspective, I can't extract what I need from it. Whereas the data that Johns Hopkins produces, or some of the data visualizations from some labs from U of T, is useful. But I question, are they getting it from the same source? All of this to say that, of course, data and therefore information is one of the key tools that we need to attack this thing.
Yeah.
That brings it right back into the health systems domain, a manageable item. I tell people all the time, this is not an apocalyptic event. It's not an extinction level event. It's not the zombie apocalypse. We're not going to be living in Mad Max world in a year. This is just a really bad health systems failure. But we can turn it around with the right focus in a matter of months.
Wow. Yeah, because I think one of my anxiety points was realistically, when it comes to dealing with this is how long for, and obviously there's still a lot of unknowns regarding how long we got to keep this up. But I do like what you're saying that, this is manageable. We just need to have the right approach. You also brought up the point too, just going back to the big data thing. I think often we don't, in research in general, this is a bit of a soapbox point, but we don't ask the phenotype question enough.
who exactly is most likely to die from this or be infected from this? Like, these are questions that would be so valuable in so many ways. Like, as simple as you and I both have acid reflux. We take the same proton pump inhibitor. Yours is effective, mine isn't. What is it about you that makes it more likely to be effective? Same thing with COVID, and you end up on a ventilator in ICU. What is it about you, really, that's making you more susceptible? Right. And there's tons of data out there.
Yeah, absolutely. And we won't know the truth of this
for a long time,
for another couple of years. Right? But I'm impressed by Iceland. Iceland has taken a fairly scientific approach to their management of their epidemic. And mind you, Iceland is a tiny country, about 350,000 people. In addition to deploying their regular testing like we're doing, they do random sampling as well. And they've given over the random sampling to a company called Decode. So a private organization offers free screening tests to Icelanders. And so they've got a grasp of the actual true prevalence of COVID-19 in their population. I think their estimate is 0.89%, which is an inspiring number. If we can translate that to Canada, that brings our burden down to several hundred thousand. Is that right? I can't do math right. Right. So that allows them to strategically target which portions of the country need the most public health investment.
Wow.
Which ones probably need to be more isolated or quarantined. That's the kind of power that data can bring to bear in managing this thing as we return to normalcy. So as I've been telling people, pandemics come in many waves, or many phases rather. I like to think of it that there are two major phases. The first phase is in the sporadic, isolated case phase. And the second phase is the growth and community spread phase. We're in the second phase, the exponential growth phase. But in that first phase, public health can do a great job in preventing it from getting to the second phase. So a good sentinel surveillance system could detect a case when it manifests. Public health is thus empowered to quarantine that person and do intensive contact tracing. Those contacts can then be identified, tested, testing is key here, excluded or confirmed, and then isolated again. That prevents the rest of society from having to deal with it. The second you get to that second phase, where we are now, then the role of testing as a mitigation strategy or tool is diminished. And now testing is all about something else. So I'm talking about many things at once here, but people ask me about the role of testing all the time. I see it as testing as three roles, depending on the lens that you look at it through. The public health lens sees testing as a way to identify people that need to be restrained, isolated, and traced. The clinical lens sees testing as a way to figure out who's got the disease so we know how to treat them. And then the third is the health systems lens, which is testing as a way for us to get information in order to plan for the future. So in the second half of the epidemic, this growth and exponential growth phase, the testing is more in the clinical realm. Is people come to the hospital, I probably got COVID, let's test you to make sure so we know how to treat you. Right? And the opportunity for screening the population is a bit diminished. As that curve bends and we return to some semblance of normalcy with a percolating, bubbling set of a few cases per day, then we can return to the realities of that first phase and use the Iceland approach with constant random sampling, with an intense sentinel surveillance system, and improved powers of public health to restrain, to fine, to punish, to isolate, to prevent this from happening again. I mean, we were talking about email. You asked me how some of the other countries are doing, and I did a quick scan of what's going around the world. It's really interesting seeing how different countries have responded to this. Israel uses their counter-espionage system to track cases, which is so interesting from a political and civil rights lens, right? Yeah. So I'm not sure how long they can maintain that until there's a mass uprising. That's the sort of idea of an intense, empowered public health system.
Wow.
Can we bring to bear the full powers of our technological society to identify cases and compel them not to spread to others? And that brings up the idea of how different cultures react as well. Probably the two countries doing best are South Korea and Singapore. And Singapore is an example we always turn to, as they've maintained their case fatality rates at 0.3%. Ours is around 1% now. So 0.3% is astonishingly low. And, they have a strict testing program and a strict containment program as well. But they have very compliant citizens who are more likely to respect authority and will stay home when the government tells them to stay home. We don't. Yeah. So our cultural difference here, I celebrate our liberalism. I celebrate our sovereignty of the individual right to be what we want to be. That's proving to be a barrier in how we can best manage this. So the need to empower public health to quash individuality. It pains me to say it that way.
Temporarily.
Temporarily.
Man,
yeah. These people.
I'm loving this because I'm learning a lot here, actually. So, like, I'm 4 years old, because you've alluded to this. In terms of, this sounds strict, or I don't know what the word is, but keeping ethics, with ethics and consideration and culture as a consideration, where do you think has been the best? Like, do you think the Iceland model is the best one out there? Considering, that we do have a very relatively liberal society and, a lot of attitude of like, fuck the man, but like, where do you think is doing it the best?
It's an interesting question, and best is a difficult question because what's best for them might not be best for us.
Yeah.
There are cultural constraints, there are demographic constraints, there are a lot of geographical constraints. Iceland and Singapore both benefit from being island nations with small populations. South Korea is doing well as well, and they also have a fairly more compliant society than we are. South Korea's and Singapore's strength was, again, testing at a scale that we can't imagine. Right? I think they test like 1 out of every 200 people gets tested, and they have a 10-minute fast test. Our test.
This is the other thing. Like, why aren't we getting a hold of this shit? You know what I mean? Like, if it's out there, it's 2020. Be like, yo, dog, can you pass that test over here? We're willing to pay. You know what I mean?
Well, Abbott Labs has a new 5-minute test, and they're going to ship out 50,000 a day starting this week, I think, to the U.S.
Okay.
And so there's a whole suite of new kinds of tests coming of it. Again, goes back to what I said about our biosciences sector really stepping up their game and showing what they can do. So this is not 1918. This isn't even 2009. This is 2020, a whole different technological regime that must come to the fore and show what they can do. So in South Korea, they also use their telecommunications infrastructure. So when you submit your test, there's a 10-minute. It takes 10 minutes in the lab to process the test, and they can get you the results that same day by text message.
Wow!
So you are texted on your phone, hey, you're tested positive. Stay the fuck home.
Wow!
And with a confidence that the person will stay home, and there will be public health follow up. We can do that too. This is where the politicians can step in. It takes political will. It takes empowering public health with the right legislative tools. And it takes some more legislative creativity to engage, for example, the telecommunications network and infrastructure and businesses to be on board with these sorts of plans.
But this is why you're going to hear me amped up for a bit. This is why we have to have conversations like this, dog. Like, I literally, excuse my ignorance, but I had no idea that level of testing and infrastructure is being implemented throughout other places in the world. And that level of technology in terms of the advances of testing are happening that quickly. Because that's a whole different ballgame. That is a whole different ballgame. And if we can have these conversations, encourage our lawmakers, encourage our health authorities to step up and amp this up, this will allow us to get to a normalcy. What's the
pseudo
normalcy, relatively speaking, on that scale, closer to reality sooner than later.
Yeah. So imagine.
Good. You're more important.
Imagine, if we have this full suite of tests at our disposal, deployed at saturation levels across our society, And now you have to go to the dentist. Now, when you go to the dentist, you're spraying all kinds of stuff into the air, your aerosols and so forth. And so if you're test positive, you are likely to be contaminating the dental suite. So we want to know before we give you a dental treatment whether or not you test positive. So if you go to the dental office, we can give you a 5 or 10 minute or 15-minute test on the spot, on-site testing. You sit in the waiting room. 10 minutes later, you know if you're positive or negative. The dentist knows whether or not they need to get fully gowned to treat you and disinfect the room, right? That takes a little more time, but you can still get your service.
Exactly. You could still get the, like right now, there's people that are not getting their semi-elective cancer surgeries. They're not getting their hips done because, and right, like in March 31st, 2020. And if we had those rapid testing, like right now, everyone in the OR, you're assuming they could potentially have COVID because you can't get the testing that quickly. So like, you're getting more PPE, more way less efficient, less cases being done, more people suffering, less people that are active in the economy. Like what you're throwing down is the ticket, Ray. It's the ticket.
Take it, exactly. Imagine, a nurse going to the hospital. She does a quick finger prick plasma test for either for antibodies or for RNA fragments, and can know in 15 minutes if she is safe to go into the hospital to give care. And that would be a daily basis. If you test negative today, you may not test
snap, right? Tomorrow. Like, how many of us are like initially too had to be self-quarantined and like part of the workforce that had to be put at home and not being able to help out because of potential exposure. And now like you want to be able to, like, in case we do get we'll talk about projections in a bit, but in case we do get hit hard, not having that manpower, we've seen that in Seattle, we hear that in New York, working crazy hours, you hear it in Italy. And like to be able to have that test and to be able to come back and contribute and help out everything.
Yep. So that's, again, the health systems angle of it. At an epidemiological population angle, what's coming soon is the home-based test. I think that's being rolled out in the U.S.
That is right? Money right there. Like, so that's legit happening.
It's legit happening, right? So I think 3 companies have been cleared by the FDA to start shipping their stuff. So you order the test at home, you do your swab, you send it by mail to the lab. A few days later, you get your results back. Are you negative, are you positive? Now, imagine that as a serology test. Well, that changes everything. Boom. Suddenly, are you immune, yes or no? And then maybe we can issue some sort of identification card. I'm immune. I can go to this concert. I can go to this.
Yeah, you can go to run the jewel. You know what I'm saying?
Right. Yeah. There's going to be some fraud issues, clearly, but it's a path forward.
It's better than where we're at now.
That's right. So, and I bring all this up. This isn't science fiction technology. This is technology coming down the pipeline now, and some of it exists now. And it means that we can return to a sense of pseudo-normalcy in foreseeable future. Not like 2 years from now, but months from now. So I'm an optimist now. I'm an optimist by nature, and I wasn't for a couple of days, a couple of weeks ago. I wasn't. I was actually pretty gloomy, and my girlfriend's very concerned because she'd never seen me depressed before. But then I took a hard look at the numbers and realized, you know what? We can get through this. And all it takes is a bit of will. All it takes is some will and plan.
Yeah, and honestly, conversations like this, getting the public more informed of what the power of public health is, people that are more influential than any of us might be able to promote and advocate for some of these tools and tests to get to the forefront, There
are a lot of reasons to be optimistic. I mean, there is, again, the flotilla of tests coming our way. Did
you just bust out flotilla? Again, is that what you just bust?
I busted out flotilla, yeah. There's the pantheon of new treatments. That is readily becoming available.
I'm all about flow. I'm gonna bust that out. You check out that flotilla coming through. Yeah, I dig.
Right, and I forgot what I was going to say. The optimism angle. Oh, and then there's I don't think that weather is going to change this dramatically, but there's some data suggesting that the increased temperature and increased humidity will decrease transmissibility by a measurable amount. As the summer months approach and people spend more time outdoors, transmissibility will also diminish. So there's positivity there. And then there's the idea of the virus mutating slightly. over many generations, most pathogens mutate towards less lethality because the environment selects for those ones that do not kill their host. And so eventually that's what's going to happen here. So again, this is not an apocalyptic event. This will be fine.
No, that is, man, I'm getting up and ready to do some jumping jacks after that. Or roundhouse kicks, as we talked about before.
Right. I mean, but having said that, there's still people suffering, and there's still people losing their jobs, and I think about them every day. So this is why we need to find a path forward that gets us back to pseudo normalcy as quickly as possible.
Yes, this is why we got to hustle. Like, I mean, thanks for listening to that Paul Offit one. It was just kind of, for me, it was about, maybe thinking about some solutions because of how long we might need to be socially isolated, or even getting our society collectively to hustle to solutions. Like, what are we going to do to really deal with this? Because I know in my inner core, I do think people will suffer and die if you have prolonged social isolation. I truly believe that. And so, I think this is why it's important to have these conversations, and it's important to act and get the ball rolling. Because we're both in Ottawa. It's red tape capital of the world, and one of my other concerns too is that we don't get caught up in red tape when it comes to innovation, like what we're talking about. Like, of course, we want to make sure the test is reliable. We want to make sure the test is safe, but don't get too caught up in having 9 administrators having to check off on something.
Here's a scary but probably true statement that I may regret in a few months, and that is, in the long run, it's probably cheaper to pay off all the liability lawsuits coming from failed tests than it is to sustain this assault on our economy.
No, it is controversial to say that, but there is some truth to that for sure. Like, I think when it comes to when you're in a situation where you're desperate and you things can't be as vetted as you like, and time is of the essence. I think it just comes down to what are you make a shared decision making process. Like, what risk are you willing to take for us to keep going?
On that note, I don't know if you're aware, but there is a proposal for a challenge trial for one of the new vaccines. A challenge trial is it skips through the phase 3 safety trial and efficacy trial. And this is put forth by Mark Lipsitch of Harvard. And it says, if healthy volunteers are willing to accept the risk of possible death and other bad effects by an untested vaccine, they should be allowed to do so, in this case, if it hastens the arrival of an effective vaccine to save all of humanity.
Wow.
That's their argument.
Look at talk about throwing down some ethics.
Yeah, I admire them for putting this in writing and for putting it out there and see what the world thinks.
Wow. I wonder what the opinion is, because my personal opinion is that because the virus is not ultra lethal, for me personally, there's zero chance I would put myself at risk for that. Like, I know that there's a lot of people that are at risk, but as a relatively healthy person, I don't know why I said relative, I'm healthy. Yeah, for me personally, there would be zero chance of putting myself at risk. But maybe there's, there are better people out there.
There are better people out there. Also, there may be, incentives.
Yeah, of course.
Financial or otherwise.
That does bring up some ethics.
Absolutely it does, right? So who will take that bait? It might be the people who are struggling to pay their bills. Then you're taking advantage of people's, of financial vulnerability. So this whole crisis is going to be fed upon by academics from all stripes for decades.
No kidding. Wow, that man, Ray throwing knowledge throughout this show, dog. This is phenomenal. Let me pick your ear on the projections. So, in terms of the way things are going now, and I'll let you answer this any way you want to. Say if we, in our current state with our current social isolation processes, what you think the future looks like, or if we weren't as aggressive, say, as our counterparts in the States, or the extreme example in Italy, what Canadians would expect? However you want to answer that, I'm happy with.
Okay, let's start with what would happen if we had done nothing. Right? So some quick calculations. We have a population of about 37 million. If we let the disease run rampant, it'll probably stop when we achieved herd immunity, which is like 60% of the population being infected. So 60% of 37 million is 22 million. I think our hospitalization rate for this disease most recently is 6%. So that would mean over 1 million hospitalizations in a country with 57,000 beds. So that's not a good thing. And if we use our current CFR, which is CFR is the case fatality rate, for people who don't know, of about 1.1%, that would mean over 200,000 deaths. But given that the hospitals would be overrun, the CFR would be higher. And if you were to use the global CFR average for COVID, which is about 2.3%, we're looking at 500,000 deaths, if not more. So if we were to let it run rampant, I think within one disease cycle, like 2 months, you're looking at 500,000 dead Canadians, right? Which is not good. And if I'm wrong by a factor of 10,
it's still crazy.
Then you're looking at 50,000 deaths, right? Which is not great. If I'm wrong by a factor of 100, you're looking at 5,000 deaths, which is not great. So either way you look at it, doing nothing is not an option. So that leads us to, now that that first phase of the pandemic is done and the options for testing and isolation are off the table, all we're left with is distancing and or lockdown. So that takes us to the modeling. And I'm not a disease modeler, but I've dabbled a bit. And we talked offline that my one paper on disease modeling was modeling a theoretical extraterrestrial disease.
Dun, dun, dun.
Which will be a future podcast, I hope. That'll be interesting. But the way that we think about disease modeling is we envision 3 compartments: susceptible people, which is everyone who can get the disease; the infected people, those who got the disease; and the recovered people, those who got it and then got better. And from the infected, you also get people who die, right? So and who are hospitalized and then die. So if you picture 3 pools of people flowing into each other, that's kind of how the formulation of the math was first achieved, by looking at engineering, flowing of water from compartments to other compartments. So we call this the SIR model: susceptibility, infectivity, and recovery. And to do that appropriately, there are at least 2 differential equations that we model. One equation for the flow of the susceptible people to become infectious, and one equation of the flow of infectious people to be recovered or sometimes to die. But some of the new modeling techniques, one is pioneered by David Fissman, who's in the news a lot these days because he developed something he calls the IDEA model, IDEA, which stands for incidence, decay, exponential, and adjustment. And the brilliance of his model is that it accounts for an intervention. So let's go back for a second. When I talked about the SIR model with those compartments flowing in differential equations, the idea was this is how diseases flow. People get sick, people recover. Done. We just model it. But we don't consider the fact that sometimes things change. Sometimes the disease changes, or hospitalization interventions changes, or public health interventions cause a change. So Fissman's IDEA model allows us to understand that if we were to intervene at a certain point with social distancing or isolation, then the rate of change, of flow of these factors might be altered. So a lot of us have been messing around with his IDEA model, and he's one of the leaders in publishing the BC projections, showing that that British Columbia might have leveled off and might be diminishing as a result of his model. So based upon his equation, I think we are looking for a flattening of the curve within the next 2 weeks. Right? And this is due 100% to our efforts in this society to isolate and to distance. That's why I'm so furious every time I hear stories of a house party somewhere in Gatineau or some kids got drinking in the park together. It's like, dude, every time this happens, you lengthen everyone's stay in lockdown by another couple of days, if not longer, every single time. So a friend had asked me some weeks ago for some positivity out of all this, and I wrote him some schlock, not schlock, actually good words, about how this is an opportunity for humanity to be heroic at a level and in a way that no previous generation has had before. Other generations, when called to serve or to be heroic, was in wartime very often, where you're called to kill people, which is innately
Go
immoral.
on a boat, you know what I'm saying? Get away from your family, not knowing if you're going to see them again. 100%.
100%, right. Whereas this time, you're being asked to do something innately good. There is no downside to this, no badness to this. We're fighting an inhuman foe, a viral foe. Stay home.
Yeah.
Right? So it's an opportunity for everyone to come together as one enormous army to fight one insidious creature that deserves to be killed.
Wow.
A virus. Right? No, there's going to be no PETA rights asking them to preserve the rights of the coronavirus.
And sorry to interrupt, right? But just to reinforce your point about if we're, 2 weeks away from flattening the curve, like in acute care, I can speak for in Ottawa right now, we are managing. You know what I mean? Like the hospitals aren't being overrun. Our numbers are quite reasonable. And so like if we are legit in a couple of weeks able to have that curve flatten, we could cope. You know what I mean?
Yeah, won.
And so like just to inspire some other cats, like, yes, we're not going to war. You're just having to stay home, dog. But two, like what at a hospital level in March 31st, 2020, this is working. Okay. So like, let's keep it up, yo.
Let's keep it. Now, of course, the other shoe is that we can't keep this up forever. Yeah. The economy will collapse. People's mental health will suffer, all this stuff. So we need a staged reentry into society soon, with probably by the end of next month, that should begin. And that staged reentry begins with the least vulnerable of us, to the extent that we're able to identify those people, and probably begins with healthcare workers, other emergency workers. And then as the summer unfolds, more people return to work. And again, when the serology test gets here, that will be the game changer. Not the vaccine, the serology test. Right? That's what people should look forward to.
Is it a fair question for you to ask, like, if you were to, like, you kind of answered this, but, if you were to lead the staged reentry into normal life, like what your approach would be?
I don't know, man. It's a good question. And I think you begin, obviously, with people who have recovered from the disease.
Actually, that's a good point. That's a really good point.
And with the assumption that they're immune. Maybe they're not. If they're not, then we're really screwed. So let's assume they are. Let me just say, for the record, there is no evidence that they are not immune.
Yeah.
Right? There's a couple of scary stories coming out of Asia of reinfection, but those are 100% due to false negatives on the tests.
That's good to clarify.
And so at the very least, you're immune for a number of months, at the very least. And that gives us more time to develop more interventions. So you begin with the recovered people. Then you move into I'm thinking on the top of my head here, but the people who the recovered people are most in contact with and who are also not vulnerable. So they have some sort of localized herd immunity. So then what non-vulnerable means, though, is going to depend on the science. There is a misconception that only the elderly are vulnerable. And that comes out of China. We saw mostly older people, particularly older men who smoked, dying of this. When we got to Europe, that changed a lot. So Europe, Italy in particular has a higher age skew, which is understandable. But we have a lot of middle-aged people suffering with the disease. And I think that has a lot to do with behavior, with fitness, with smoking. And then when we got to the USA, well, it's pandemonium. It's unclear who's getting it there. But I suspect it's a lot of obesity, diabetes, and other respiratory issues that are under-acknowledged, maybe even some nutritional issues. So I think people are largely unwell in American cities, and that unwellness is manifesting as a vulnerability to this infection. So when it comes to how Canadians deploy or stage our reentry, we need to take a look at our demographics and the extent to which our population is susceptible to things like obesity, diabetes, and other underlying respiratory issues. The science will guide us, and it's not data that I am privy to at the moment. But,
and I don't know if this is true too, but I mean, I feel like when it comes to like steps similar to this, almost nothing is nuanced. So, I do think when often government or public health, I should say government, would reintroduce some level of normal, like going back to regular life, they'll try and it will be a group. Do you know what I mean? Like I see it being like, I don't know, kids could go to school, or maybe, as you said, the people that have known to be infected. It's just the problem is like, how are you going to identify them and all that stuff? I'm just thinking out loud here.
Sure. No, I mean, that's a procedural issue. That's not a scientific issue. That's an administrative issue that can be solved by our overabundance of administrators. Right. Well, one thing we do not struggle with is a lack of administrators. Yeah, I mean, schools have to reopen, daycares have to reopen.
Yeah.
I mean, I'm a university lecturer. Universities are going to reopen in some capacity come September. Something we are not closing. Maybe online classes or some limited in-person engagement, but that's going to happen. We have research agendas that require people to be in the labs producing knowledge. That's not going to slow down or stop. So yeah, that's the way it's going to work. And by the way, we talk about the soldiers and the heroes of this crisis. We always talk about the healthcare providers. Number one, absolutely, that's the way it should be. But I want to point out that there's an army of unseen people keeping our society afloat, especially at nighttime. Anybody in a high visibility jacket is a hero in my book.
100%. We at Solving Healthcare have been trying to, improve morale and support some of those frontline workers. And, we start a project where we feed our frontline workers and support families also that might not have as much resources as others. But
yeah,
luckily
the cleaners, the chefs, the drivers, all these people,
exactly.
Cashiers.
Luckily, there's been a lot of initiatives, not by us, but by some other people throughout the city to support exactly what you're describing, like the person working even at Starbucks right now, or delivering your food, like they're putting themselves at risk, and
absolutely, and their families at risk.
Exactly. So I'm really glad you said that. And to be honest with you, we're also not mentioning some of these behind the scene like people like yourself that are giving us more knowledge and the science.
But to be blunt, though, I'm not at risk. I'm at home comfortably behind my computer.
For sure. But what you're
and being well paid for it. So don't feel sorry for me.
What you're doing is helping regardless. And I think it needs to be said. Ray, I got to thank you so much for doing the show. I learned so much on this episode. And I got to tell you, it was empowering. And like, not just empowering, it's like hopeful. And there is reason to be hopeful and optimistic. And you really hammered home some points that I think we're not talking about enough. And I can't thank you enough for this. And I'm going to tell you, we're going to be doing this again, son. This was knowledge being thrown down like mad crazy. So yeah, I really think
I feel 20% cooler just being in your presence. Like your coolness has rubbed off on me.
Oh, it's contagious. Not as contagious as COVID-19. Stay home. But I really appreciate you doing this. And honestly, thank you so much.
Thank you. All right.
Thanks, everybody, for listening to our conversation with Ray today. This was awesome. I hope you guys enjoyed it. If you guys want to leave any comments, leave them at quadcast99@gmail.com. Follow us on Twitter and Instagram and YouTube at Quadcast. See the links on the show notes if you want to contribute to our frontline workers GoFundMe fund or our Bridges Over Barriers charity to help support families during this tough time. Also want to thank our sponsors, BetterHelp and Audible. See the links below as well. Thanks everybody for listening. We're going to talk to you soon. And everyone stay safe and stay home. Thank you.